All right. Well, it's noon on the dot on a Friday in the first Friday in August. This is Brandon Gare with the National Minority Equality Forum. And this Friday, we're here to, as I say, edutain everyone and give you some insights on the stuff that we're working on in the health and healthcare space. This is kind of exciting because if you know NMQF, you know that we're six centers and we're one big nonprofit with six other smaller nonprofits in it. And one of them is CSSR. And this is probably by far the most, there are more commas behind names in this group than I've ever seen in any other group anywhere, but even at NMQF, everybody has. Well, this is the Dr. MPA group of folks that are very well highly educated and know their stuff. So um, I got to turn it over to a guy that needs no introduction, Dr. Puckrein, and a group of people that are far smarter than me that can go ahead and lead today's webinar and tell you what they're doing in the Cancer Stage Shifting Initiative. So without further ado, Dr. P, it's on you.
Good afternoon, everyone, and thank you for joining us. I am really excited today to have our clinical and social research team before you. As Brandon suggested, we've got a really high-powered team of folks that sit behind a lot of the work that NMQF does. NMQF is a data-driven organization, and as you're going to learn or relearn, we do a lot of publishing, we do a lot of statistical work, and these are the folks behind it who do the work. So I'm going to start off by asking them to introduce themselves a little bit to you if you don't know them. And I'm going to start off with Liou Xu. Dr. Liou Xu, please.
Hello, everyone. My name is Liou Xu. I have a background in statistics. I earned my PhD and master's degree from the University of Kentucky. My academic training focused on developing statistical models to better understand complex health outcomes, including dementia progression and competing risk analysis. I have been working in healthcare data research for over 10 years. Currently, I serve as a senior principal statistician and vice president at the National Minority Equality Forum, where I lead the Healthcare Data Equity Project under the Center for Clinical and Social Research. I've led research projects using real-world data, especially Medicare and Medicaid claims data, to address healthcare disparities, improve health equity, and generate insight into treatment patterns, disease burden, and healthcare access for underserved populations. My work spans multiple therapeutic areas, from cardiovascular disease and diabetes to influenza vaccination. At NMQF, I provide scientific leadership on study design and data strategy, collaborate with both industry and academic partners. I'm excited to be here today and look forward to sharing some of our team's research work. Thank you.
Dr. Xu. Christina Edwards.
Good afternoon, everyone. Christina Edwards. I work as the Director of Clinical Trials in our Center for Clinical and Social Research at NMQF. I earned my Master's of Health Administration from George Washington University here in DC. I have over 10 years in the clinical research space, working on both industry-sponsored or NIH-funded clinical trials. I have some experience in working in pediatric trials as well. Some of the therapeutic areas I've worked in as far as research is concerned, in pulmonary critical care, gastroenterology, and CNS studies with a focus on mental health disorders. I lead our Alliance for Representative Clinical Trials and our My Clinical Research Network, which you'll hear a little bit more about later on.
Great, thank you so much. Dr. Jennifer Matisse.
Hi, everyone. I'm Jennifer Matas. I have a PhD in epidemiology with focuses on biostatistics and data science. I earned these degrees from UT Health School of Public Health in Houston, Texas. I'm a health services researcher by training. I specialize in studies focused on health disparities and health equity. Most of my research experience and publications have focused on maternal and child health, particularly in severe maternal morbidity and birth defects research. However, I also have experience conducting research on chronic condition conditions. Most of my research is focused on big data and analytics using administrative claims, be it our CMS data, Medicare and Medicaid data, but also Optum data. And here at NMQF, I'm a lead research epidemiologist with the HSTEPS team. Looking forward to continuing the conversation.
Great, thank you so much. Dr. Derek Fournier?
Yes, hello everyone. My name is Dr. Derek Forney. I am a health outcomes scientist and epidemiologist with a background in biostatistics, public health, and health disparities. I hold a PhD in public health from Florida International University and a master's in public health from Michigan State University, where I focused in HIV and mental health disparities, disease prevention, and quantitative research methods. I continued my career in academic research as a postdoc fellow at the University of Miami Miller School of Medicine and Department of Biostatistics. There I supported NIH-funded studies in HIV prevention and behavioral health. I've developed predictive models using machine learning algorithms and published in peer-reviewed journals such as AIDS and Behavior. Just last year, I joined the National Minority Quality Forum as a research epidemiologist in the Center for Clinical and Social Research, where I lead health equity-focused studies using Medicare claims, patient-reported outcomes, and real-world data, resulting in client reports and manuscripts. I am a team member of the Healthcare Data Equity Projects team, and also the co-lead of the Minority, Rural, and Coronavirus Insight Study, which we'll be highlighting a little bit later. Thank you.
Thank you so much. Dr. Michaela Coudray?
Hi, good afternoon, everyone. My name is Dr. Michaela Coudray. I am an epidemiologist and implementation scientist by training. I did my PhD in epidemiology at Florida International University, and I did a postdoctoral fellowship in implementation science at Washington University in St. Louis. I'm also a postdoctoral fellow at Fordham University in research ethics. I have been the PI of multiple NIH-funded studies that focus largely on sexual and reproductive health and minoritized communities, as well as implementing community-based participatory research models, which we hope to discuss a little bit more later on. At NMQF, I am an epidemiologist within the Center for Clinical and Social Research, and I serve as the co-lead along with Dr. Forney for the Minority and Rural Coronavirus Insight Study, as well as the data manager for the Kansas State Statistician Initiative that we will discuss later on. Thank you.
Thank you so much. So I'm going to ask Christina to talk a little bit about CCSR.
Sure. So you'll see here a quick summary of our team. You got a good description from us, but we are a multidisciplinary team that promotes equitable healthcare by leading observational and international clinical and social research, which directly impacts medically underserved patient populations. We are powered by big data, driven by scientific integrity, and a commitment to minority communities. The CCSR endeavors to equip healthcare stakeholders with evidence-based, clinically meaningful, and socially impactful research. Our ultimate goal is to help shape, with leading research and real-world data, a health landscape that embraces the increasing complexity, diversity, and, holding strong to dignity of the global population. Our vision you'll see here, in short and precise, steering the way towards an era of inclusive and equitable healthcare by integrating clinical and social insights through data-driven research.
Thank you so much. So now we're going to talk a little bit about some of the work that we're doing. I'm going to ask Dr. Xu and Dr. Matisse and Dr. Fournier to begin.
So in this section, Dr. Jennifer Meadows and I will talk more about our work focusing on Healthcare Data Equity Project. The Healthcare Data Equity Project, or HDEPs, are designed to harness the power of big data, including large administrative claims data from Medicare and Medicaid, to explore disparities in health outcomes across diverse therapeutic areas. Our goal is to collaborate with industry leaders, academic partners, and community stakeholders to spotlight and address underlying healthcare disparities aiming to promote more equitable care for the most vulnerable populations. Next slide. I'll provide a brief overview of HDAP's core capabilities, highlighting our expertise in data management, analysis, and research. We have extensive expertise in analyzing claims data across multiple payer sources, including Medicare, Medicaid, and commercial insurance claims. This allows us to identify trends in healthcare utilization, cost, and patient outcomes across diverse populations. In addition to claims data, we are highly proficient in working with population-based surveys such as BIFSS and NHANES, along with other large data sets that provide critical insight into public health trends. We also have experience handling EHR data, ensuring that clinical insights are effectively integrated into research and policy analysis. Our team excels at data management and statistical modeling to transform raw data into meaningful and reliable insight. Beyond data analysis, we have a strong foundation in scientific writing and communication. Our team has contributed to numerous peer-reviewed publications. I have included here a link to our center's resource page, where you can find a comprehensive list of our published work from the studies we conducted. Another key aspect of our work is scientific communication. We prepare posters and presentations for conferences, ensuring that our findings reach the broader community. This dissemination of knowledge helps drive evidence-based decision-making in healthcare. We look forward to continuing this effort and expand our impact. Lastly, HDAP has deep expertise in several key areas, including health disparities and health equity research, healthcare utilization outcomes research, and big data analytics. We also offer consulting services to support organizations in leverage data for strategic decision-making. Now, I'd like to turn it over to Dr. Jennifer Mathers, who will walk you through some of our collaborative work and highlight the team's research publications.
Hi, thank you, Dr. Xu. As was mentioned, here at HDEPS, we conduct research across a broad range of therapeutic areas, and we partner with diverse stakeholders, a lot being in the pharma space, academic institutions, philanthropic organizations, and so forth. And so a lot of times we get stakeholders that come to us, and they could be at any place in their research goal, right? A lot of times we are asked to not only do data management and analysis, but also conduct and submit peer review articles. And this is not an exhaustive list of our published work. This is just some of the recent publications that we have here, showcasing our ability to engage in various therapeutic areas and partner with a wide range of stakeholders. So a couple of them, a recent one that was published had to do with influenza healthcare disparities. A common theme with a lot of these publications is that we look at healthcare utilization. Although we're targeting or we look at various therapeutic areas, a lot of times our outcomes are the same, in which we look at hospitalization rates, emergency department rates, outpatient care, pharmaceutical medications, and so forth. And we focus on not just infectious diseases, but also glucose monitoring and other chronic conditions not mentioned here. And we would be more than happy to continue collaborating with our current partners, and also always opening the door to new partners wherever you're at your research stage, whether it's you're trying to develop a research question, need help with your analysis, want to submit a paper. We're more than open to collaborate, and hope to hear from you soon. Sorry, go ahead, Dr. Puckrein.
I just wanted to add that, they're sitting and working on about 5 billion patient records. So we have an extensive data, we call it a community data lake with lots of of data points from which they're working with. Please, let's go on to the Mercer study, and I'm going to ask Dr. Fournier and Dr. Coudray to talk to you about it.
Yes, so the minority and rural coronavirus insight study, we can go to the next slide here. It's a 5-year perspective multi-center cohort study. Began enrollment around November 2020 and enrollment ended in April 2021. The study follows up with that cohort every 6 months and will continue until April 2026. Now, the overall goal of this study is to determine which racial and ethnic minority groups are most susceptible to COVID infection, which ones experience the most severe cases of COVID infection, and which ones are most likely to die from COVID infection. We can go to the next slide. So some of the inclusion criteria for this included adults being 18 years of age or older, consenting to the study procedures, and also presenting to one of the 5 federally qualified health centers for services. Now, those 5 federally qualified health centers are spread out across the country. We have one in Illinois, one in Ohio, one in Louisiana, one in Florida, and one in California. What makes this study so unique is that in our California cohort, we have a very large unhoused population that we have been able to follow. Also, the majority of our sample is minority. We have 51% Hispanic, 26% Black. Also, we have a site, our Louisiana site, that was completely enrolled prior to the vaccine being available. So they're completely vaccine naive. They were enrolled prior to December 2020. So I think that gives us a lot of rich data to look into. Next slide. So at baseline, we performed informed consent form, we did a baseline survey, and we also did some sample collections for testing. Next slide. So we did a comprehensive data collection. I'll actually go back. Back some more. Yes. So we did a comprehensive data collection strategy where we tested for viral presence. The antibody testing we've done. We also did a complete CBC and lipid panel, complete with A1Cs and vitamin D serums. We also done some biobanking and serum samples for future genomic testing and metabolite studies. So that's something that we're interested in partnering with people on if you're interested in that. Next slide. I think I will pass it to my colleague, Dr. Coudray.
Thank you, Dr. Forney. We were able to recruit a cohort of just over 3,500 participants at baseline, and would truly like to emphasize the national nature of this cohort. Of that sample, we had available results for COVID specifically from approximately 3,200, and we determined the prevalence in this particular sample of COVID to be just about 26%. Next slide, please. As Dr. Forney mentioned, we have a very high majority of our sample identifying as a minority population. Just above 75% identified as a minority, either Hispanic or Latino, or Black and non-Hispanic. We also had those who identified as white non-Hispanic, and to a lesser extent, the other group included such racial identities like Asian American or Hawaiian or Pacific Islander. Next slide. We'd like to highlight the disparities that we saw in this cohort. So 2 of our key findings were similar to other research. We found that age was significantly associated with COVID infection, so those who were younger were less at risk for SARS-CoV-2 infection, but we also saw that both of the minority groups in our population, the Hispanic and Latino group, as well as non-Hispanic Black participants, had a twice greater likelihood of experiencing SARS-CoV-2 infection. So these 2 groups were at greater risk of acquiring SARS-CoV-2. Next slide, please. We also saw additional structural and social barriers that impacted the association with SARS-CoV-2 infection. Specifically, access to stable housing, access to the internet, and residing in a rural area were very protective against risk for SARS-CoV-2 infection, reducing the likelihood of infection. But conversely, we saw prior history of SARS-CoV-2 or COVID-19, as well as experiencing symptoms or exposure to household members with COVID, and household sizes with greater than 7 increased the odds of SARS-CoV-2 infection. And to further comment on the household sizes larger than 7, as Dr. Forney mentioned, we did have a significant amount of the population that identified as unhoused, and they were in certain group homes or transitional homes that had large populations, which they also considered an increasing risk factor for SARS-CoV-2 infection. We have been able to publish these findings in multiple journals, which we're also happy to share and partner with for future research. Thank you. Next slide.
Okay.
Christina, you want to go?
Yes. So I'll talk to you a little bit about our ARC and my clinical program. So ARC is the acronym for Alliance for Representative Clinical Trials. It is the brainchild of Dr. Puckrein, our CEO. Back in 2021, there is a new published paper in the New England Journal of Medicine where this idea sort of derived alongside Janet Woodcock at the time. So ARC is a program. It's made up of community clinicians, essentially organized to bring clinical trials to racial, and ethnic minority communities, and of course, other communities that have been underrepresented in clinical trials. It was created to help fill the deficit of these populations, the lack of inclusivity in clinical trials, and sort of get them active and participating, eliminate some of the barriers to entry, and allow them to have a voice in clinical trials. Under the Alliance for Representative Clinical Trials, we have what we call our PI Institute, our Principal Investigator Institute. So we provide research training, the required fundamental research training to become a principal investigator. We work with a contract research organization that provides a pretty good, foundation of what is required, what a good introduction to clinical research. It is done with a live instructor, It is 13 hours, so it is intensive. And we think that gives, rather than the usual, which they do as well, because it's essentially the standard across, they do city training, their good clinical practice and human subjects research training, but we also provide this add-on, this supplemental training that provides a bit of a boost. We also conduct a feasibility assessment with these new sites. The feasibility assessment essentially helps to inform us, engage their research infrastructure and trial readiness. Where the starting point of their research, this inexperienced research site may be, what are their needs, what are the gaps, and what can we do to bring them to the baseline level and help to qualify them as a viable research site. ARC, we also received support from the FDA. We have a manuscript that you all can be on the lookout for that should be published soon in the Journal of Translational Science that you can be on the lookout for. Essentially covers the feasibility of the Alliance for Representative Clinical Trials, the framework, the model, and our lessons learned and what we will need to expand it and allow more research naive, those who have minimal research experience to join and be a part of it. So once we worked with these obviously motivated, newly trained clinical investigators who are now credentialed to be PIs, they essentially matriculate into our MyClinical Research Network. So MyClinical essentially operates as a full-service investigative research network. It is designed to empower these clinicians, these clinicians that have received this training, the support and guidance. They may be from federally qualified health centers, because note they are within the community. So federally qualified health centers, any freestanding clinics, any private practices that's more community-based rather than your larger, more well-known who clinical trials and industry sponsors tend to go to. academic or hospital institutions, organizations. So the network is envisioned, MyClinical, to serve as a single entity that will represent these clinic sites. We liaise with sponsors. We essentially help to streamline and coordinate any clinical trial activities, alleviating some of the burden from the investigator and the clinic site. We know that, essentially integrating a new service line, which is what clinical research will be for these new sites. It's a lot to handle. In MyClinical, we work with the site, we work with the sponsors to actually serve as that in between the two. So we collaborate with research and experienced clinicians to provide guidance and mentorship. We also align them with experienced clinicians and those who have experience in clinical trials to provide sort of that guidance and mentorship and that one-on-one experience that they'll get as they're newly entering into this space. We currently have about 19 sites, which you'll see where we are on the map. 19 sites from, again, fairly qualified health centers. We're in California, Arkansas, all down to Texas. We do have a few universities that have signed on. We're working with Texas A&M, and we have some sites in DC, PA. You'll see the list of sites on the next slides. Some of the specialties that we have among these 19, we have obstetrics and gynecology. We have quite a few cardiologists. We have rheumatology. We are working with some pharmacists as well, and a lot of internal medicine and primary care services provided as well. We have a few of our sites who have already had the opportunity to work on some industry-sponsored trials, and we are open to taking on any more and working with our sites that are ready to conduct clinical trials. Next slide. Okay, so CSSI, our Cancer Stage Shifting Initiative. It's essentially at the current time, one of our principal projects that we're working on under the MyClinical Research Network. Our Cancer Stage Shifting Initiative. It's a clinical observational research trial with the focus on we are aiming to transform healthcare delivery through early disease detection and prevention in historically marginalized communities. Here at NMQF, we see early detection as the future of healthcare. What you may know already is most diseases, including infections and chronic conditions, they develop along a predictable biological timelines within populations. And knowing these trajectories, there is a critical window for early detection and intervention. So with the advances of liquid biopsies and early detection technologies, there is an opportunity right now to use these tools for population-level cancer surveillance that are capable of identifying disease signals before symptoms even arise, especially, again, in marginalized communities that have historically been left out of these medical innovation, particularly those we'll talk about a little bit more experiencing environmental pollution, health risks, and they have limited access, again, to these advanced diagnoses that others already, have the privilege of using. So while the application of liquid biopsies for asymptomatic individuals is still emerging with questions surrounding cost effectiveness and clinical utility, our effort with CSSI essentially represents a critical shift from reactive treatment to proactive and equitable care. That's our goal here. And we want to intervene when diseases are most treatable, and we believe CSSI offers an opportunity to improve, on the outcomes and disparities that happen with that. So our study design for the trial, so we are employing a community engagement. It is healthy community involved to address community-level health population. It is an all-comers, non-interventional study design enrolling participants, residents of the community that we enter at 35 years of age and older. We offer a comprehensive surveillance using novel early detection technologies, i.e. liquid biopsies. When we say liquid biopsy, we essentially a blood test. It monitors multiple disease states simultaneously. So participants are enrolled in the study for 5 years of annual study visits, followed by an additional 5 years of long-term follow-up. At these visits, biological samples are collected annually, along with annual surveys and a review of participants' medical history, as well as their electronic health record. We also provide a comprehensive cancer biomarker panel analysis. So what we're viewing, how we've organized this project, and what we can see as the community benefits to those that are in these communities, is the study essentially addresses the disproportionate burden of industrial population affecting medically underserved cancer care communities. We have an acronym for that, MUCCC. So they're contributing to ongoing environmental and health inequities. We also see as a benefit as access to improved care. By bringing these advanced diagnostic technologies directly to the community, the study helps to bridge any gaps in access, some of the gaps in access to early detection. There's also a benefit we see of representation in research. That goes back to our Alliance for Representative Clinical Trials and our My Clinical Research Network. The CSSI initiative promotes greater inclusion, of historically underrepresented populations in clinical research, leading to, equitable findings that everyone is represented. And we think we're building a lot more trust and accountability in the communities that we're going in. The study design acknowledges and responds to historical concerns about the exploitation of marginalized communities in medical research. And NMQF is making a point to, highlight transparency, informed consent, and community engagement. I would like to talk to you a little bit about from the epidemiology perspective of implementing this study, Cancer Stage Shifting Initiative. Michaela, can you tell us a little bit more about that?
Yes, I can. Thank you, Christina. I think a question that's often raised is why focus on cancer? Because recent data has shown that overall cancer mortality rates have shown a slight decline in recent years. But even in that decline, we see significant disparities, specifically racial and ethnic disparities, where racial and ethnic minority groups are still significantly impacted by cancers across the board, regardless of the type of cancer. We see disparities first at the level of screening, where racial and ethnic minorities are screened far less frequently. We see disparities in terms of morbidity, where racial and ethnic minorities, particularly Black populations, experience more severe cases of disease. For example, Black men have the highest rate of prostate cancer incidence, and they also experience more severe cases of prostate cancer. And then these disparities further extend to mortality, where Black men also experience the highest rate of cancer mortality for prostate cancer. We also see significant geographic disparities, meaning that there's certain locations that have higher rates of cancer. So for example, in the southern states, we have the Cancer Belt. We also have the Appalachian regions who show elevated cancer mortality in these areas. We also see that rural communities tend to have lower screening rates and delayed diagnoses, contributing to worse outcomes. As Christina mentioned at NMQF, we are moving towards a model of early detection, and we see this being significantly impactful in reducing ultimately cancer mortality, because if we can disrupt the pathway earlier on to implement screening, we can intervene early enough to prevent one, serious morbidity, and then to prevent ultimately severe mortality. This is particularly relevant for the communities that we have identified as being historically marginalized or medically underserved.
Thank you, Michaela. So why Houston? Houston Fifth Ward serves as our inaugural site for the population surveillance approach that we're taking with CSSI. So Houston has a history of a cancer cluster. The CDC, excuse me, defines unusual patterns of cancer as specifically a greater than expected number of the same of etiologically related cancer cases that within a group of people in a geographic area. So essentially what that can answer is, are there more cancer cases occurring in that area or in that population of concern than would be expected based on the size or demographic characteristics of said population? So the findings or the hunt of discovering there was a cancer cluster started back in 2019. There was a meeting among residents and city officials in the Houston Fifth Ward, and they essentially raised environmental concerns, health concerns. Residents believed there was a link between the cancer cases and the Union Pacific rail yard, where creosote is a wood preservative, had been used. So between the Houston Health Department and the Texas Department of State Health, DSHS, they sought out to confirm that a cancer cluster existed. From there, the case eventually went on to gain some attention and traction from the Environmental Protection Agency, EPA, which required further testing, further proof of contamination. So city officials alongside union-specific representatives went door to door. They did some door-to-door canvassing, asking homeowners permission to test their soil. They also conducted health surveys, trying to gauge sort of what are any medical issues that they may be experiencing within each home. The soil sampling was done. They found some chemicals of concern, including the creosote and the dioxin, were identified within a groundwater contamination plume. There were some relocation efforts that have been, not much progress has been made, has been put on hold. And as recently as March of this year, the EPA findings indicated there's contamination on one of the zones, which I'll show you the zones in a slide that we'll put up. But they found that there was no immediate risk. So that's kind of where that's been settled on as far as the most recent update. Jennifer, are you able to show the zones? It's just so you can kind of see what the Fifth Ward area and how they broke it down in their soil testing and the area codes that they went into. So we'll talk a little bit about our community involvement in sort of bringing this study together. We have worked with the councilwoman in collaboration, Councilwoman Letitia Plummer. She is the Houston City Council representing the at-large position 4. About 15 months prior to, our CSSI kicked off, there's already conversations and ongoing efforts that she was a part of, that working with the EPA and trying to make a final determination for the relocation as mentioned, or anything else that can be done within a community. We also had some collaboration with our the faith-based community in Houston, Texas. Those are the religious institutions who we work with and serve as a trusted community anchors, providing venues for community education, sessions, and recruitment activities. And Michaela, you can go ahead and tell us a little about, so we employed a CBPR model for CSSI, and she can provide some details on that for you.
As Christina mentioned, we employed a community-based participatory research model, or a CBPR model, and this was very instrumental to our immense success in the Fifth Ward. A CBPR model essentially is a philosophy of collaborative inquiry that centers the community's voice and with an aim to improve research integrity and impact and develop equitable solutions. So at every stage of the process, we try to incorporate community feedback and insight, as well as to give the community a sense of ownership of the research. And there were several benefits to this approach. We saw that it enhanced the relevance of the study within the community, and we got to have a lot of engagement. There was a lot of boots on the ground involvement, specifically from Councilman Plummer's team, where we did door-to-door canvassing and knocking to just, first of all, build up interest and community buy-in into this particular study. We also saw that this endeavor built trust in the community. We selected a site, Grace Clinic, that was very much entrenched in serving this community, and it was familiar with the community and a common place that can be easily accessed for certain communities in the Fifth Ward. And this also furthered our trust in the community and helped us to maintain ongoing communication. We also saw this has improved our recruitment and retention. Within 72 days, we were able to recruit more than 75% of the sample. And this was truly reliant on our community involvement and the CBPR model, where we were able to implement co-created recruitment strategies along with Councilman Palmer's team and the team at Grace Clinic, and some support from the NMQF Communications Center that helped us to reach out to these communities in terms of building effective messaging that incorporated trust. This approach also promoted equity and power sharing by giving the community a chance to be involved in the process, to voice their opinions about the research. This was done early on during that canvassing session and was aired multiple times on Houston's local news, the feedback from the community and their buy-in and the interest of this project, considering the impact that cancer has had on the Fifth Ward. It also helps with sustainability. As Christina mentioned, we are initially following up the cohort for 5 years and then an additional 5 years after that for a total 10-year period. And with such long cohort studies, it's very helpful to have the community involved and to have built that level of trust. Since we've done that at the onset, it has gone to promote our implementation sustainability for CCSI. It will also help to strengthen our public health impact. We will be incorporating the community, and we do plan to share the results of the study. We've done community town hall events to share information about the study and help with recruitment efforts. And this is something we plan to continue moving forward to increase our community engagement and community footprint. Christina?
Thank you, Michaela. So Michaela introduced us a little bit, Grace Clinic. So Grace Clinic is our site that we're using to enroll participants in Houston. They are centrally located in the Fifth Ward area of Houston, Texas. They are a relatively new site, founded in 2023, late 2023. They provide primary care service to their community. They have a medical doctor there who is serving as our PI. We also have a nurse practitioner there that is serving as our sub-investigator. Grace Clinic was a research naive site. They are one of our MyClinical network sites. And now, after going through all our training and study startup, outside of working on the Cancer Stage Shifting Initiative, they're available to do other future studies for various therapeutic indications. So the training that we provide, circling back to our Alliance of Representative Clinical Trials, when we went into their site, they're research naive. We conducted our feasibility assessment. They, alongside about 13 other staff members, completed the site coach training. That is this 13-hour live virtual training with an instructor. They also went on to complete the city training, a city program training in good clinical practice and human subjects research. And of course, we had multiple sessions of the study protocol training that led up to our on-site site activation, study site startup, site initiation visit that we conducted over 2 days at Grace Clinic. A lot of the training also, They also received training in our RedCap platform. That is our electronic data collection platform that we're using to capture all study data. And Michaela can tell you a little bit more about that.
Yes, thank you, Christina. When approaching the data capture for this project, we wanted to acknowledge the history of research mistrust in the minority community, and as NMQF, we take data quality and privacy very seriously. So in selecting RedCap, we wanted to ensure that the system was HIPAA compliant, which it is, and had multiple levels of security to protect the data that we're collecting from the community. So this was one of the motivating factors behind choosing RedCap in order to continue to maintain the trust that we've managed to build in this community. We've also conducted extensive training with Grace Clinic over a 2-day period to bring them up to speed on using this system, which was very effective. RedCap also allows us to maintain communication with participants. We're allowed to send text messages and reminders. As Christina mentioned, we have a long follow-up period, and RedCap allows us to securely communicate with our participants intermittently to allow us to share timely information, which was also essential for us to maintain the trust that we have built. Christina?
Thank you. So a little bit about one of our key partners. We work with Quest Exam One. Exam One is a Quest diagnostic company. We worked with them to provide the lab collection kits. They are conducting the analysis. They also helped with building the infrastructure of helping to build the research infrastructure of Grace Clinic, providing some physical equipment, things like a phlebotomy chair that allowed us to make things more seamless in study activities. They're also working with us on our biobank. So Quest Exam One have been quite helpful and integral into our into the program. So a little bit about our launch, what got this kicked off. To start, there was some canvassing to representatives from the city of Houston did door-to-door, conducted door-to-door canvassing within the select zip codes. So some of the zip codes that I showed you, that slide in the 5th Ward community, to raise awareness about the study. We also had a pretty strong media presence on the local TV news cycle. They covered the canvassing, they covered Grace Clinic. They were routinely featured on the local news and segments in the days leading up to the first enrolled patient. We had over 66 million media impressions and over 1.9 social media engagements, spotlighting the urgency and impacting of that work. We can attribute that to our internal house communications team that helped with that. There also were some community events. Michaela mentioned, Dr. Kudre, mentioned some of them. There were town halls, there were community meetings. As I mentioned, the issue of the cancer cluster and this creosote and, the high rates of cancer diagnoses already in the area, that has already been an ongoing conversation. The EPA were in there testing the soil. So they already had regular meetings ongoing. There also was a documentary that was done that you all can watch on YouTube if you're interested. Now included presents Houston's 5th Ward Exposed, Community Contamination and Cancer. So we did an event was held for that. That helped to put more eyes and gain more interest into the trial and how the community can be a part. We think all the meetings and so forth, the media, all help to help motivate and get more eyes on it. Dr. Kudre also mentioned, as we are today, we have met our enrollment goal. The target was over 200 participants. We have met that, and I believe it what can be considered in record time in about 4 months. And, so far, this is year 1. And we, as mentioned, as far as the study timeline, there's an additional annual follow-up. But we think this first year has been a success thus far. So where do we see this going in the future? like we meant, this is just Houston Fifth Ward at Grace Clinic is just our inaugural site. We plan to expand to other locations that have longstanding history of environmental exposure and systemic neglect leading to significant cancer risk, other cancer clusters in other cities. We do have a 100,000 target participants by the year 2028 across multiple sites. Some of the cities that we plan to go to, our next one is Flint, Michigan, and we will be venturing off into Louisiana, alongside in Cancer Alley, Selma, Alabama, Robertson, Kentucky, and more. So we want to utilize this framework essentially as we expand to help transform the way that we look at diseases, the manner in which diseases are detected, and improve on population-based disease surveillance. Especially venturing beyond cancer into any other diseases, other indications. We don't want to just limit it to that. And then that is, I think Dr. Puckrein, if he has any final sentiments within the Cancer Station Initiative.
Also want to open it up for questions. If anyone has questions, they can put them in the chat and we'll keep an eye out for them. I want to do two things. One, to again, I feel like you're a proud parent here of a really fabulous team that is working both in administrative data as well as clinical data, all around looking at marginalized populations and trying to get a deeper understanding of their health outcomes. NMQF's purpose is really to reimagine how we provide care in these communities. The very word marginalized and underserved should galvanize us all to want to do something in these communities. Particularly excited about the work going on in CSSI. Here, what we're saying is advances in science are now allowing us to look at changes in blood chemistry that will allow us to go further upstream in terms of early detection of disease. And I would argue probably over the next 5-10 years, we won't even be using the word early detection anymore. We'll find new language to describe what we're able to do. By way of an example, we are expecting in the next 2 years blood tests for Alzheimer's and Parkinson's disease, and obviously we're using that for cancer. And I would argue we're probably going to redefine diabetes and the whole metabolic process that's going there, because we're moving away from symptoms-based medicine and more looking at changes at the cellular and molecular level that will give us insight into intervention. And what NMQF is doing is providing proof of concept that we can actually go into these communities, use this technology. One of the things that we haven't said to you today is some of the results that we're finding when we go into these communities. That will be a publishable paper that is going to be in the offering. But you'll quickly see that it's more than cancer that we're trying to understand and detecting population challenges well before people get symptomatic. And we're also collecting genomic data, which allows us to look at genetic disorders that may be contributing to kidney disease, to cardiovascular disease. All of that is within our ability. So that data that we're collecting in Houston and Flint and later on in Louisiana will feed into our biobank and our biorepository that we look to partner with. We look to work with others to get a deeper understanding of the health patterns in these communities that have been long suffering. So we're excited about that. Looking forward to collaborating with each and all of you. We're in this very special moment where I think we get a chance to rethink how we are delivering healthcare. So I'm going to call on some of the folks here at at CCSR about the work that they're doing. I'll start with Michaela, because she's really been an extraordinary contribution in community participatory research. What you haven't heard is that we have a Center for a Center for Sustainable Healthcare Quality and Equity, which is our faith-based alliance, barbershop alliance, and using those tools as well as our communications folks to build that community trust. And so I want Michaela to talk a little bit more about that.
Hey, Dr. Puckrein. The Faith Health Alliance out of the SHC Center at NMQF is entrenched within the community, and they operate as essentially our gateways to the community. Specifically, for an example, in Houston, that was our partner to get into the community to identify collaborators like Grace Clinic and Councilman Plummer. We do that across the nation at NMQF. We also establish what is called community advisory boards that help us in implementing our studies. For example, with the Melissa study, our community advisory board included members from, of course, 5 states that were representatives both on in-house community councils, radio hosts, who also served as our community liaisons. They were able to help us with recruitment. They were able to help with providing community feedback to study instruments. We incorporate feedback into our ongoing data collection. We update data collection instruments based on what the community says is important to them, further highlighting our commitment to community engagement and building trust within communities and building research trust.
To Dr. Liu and Dr. Mattis, I want you to talk a little bit about the work that you're doing. You're getting published in major journals like Lancet, and talk about how you do those external collaborations and partnerships to really get information out that actually affects public policy, so that we're just not publishing in journals for the sake of publishing. We then turn around and use that and apply it to really improve public outcomes. So please.
So these collaborations usually involve working together on study protocols, with our team handling the data analysis and sharing authorship on any publications. The external team usually brings in clinical and scientific expertise, while we at HDAPS provide the data and analytics support to make it all happen. And Jennifer can tell you more about the type of analysis we typically conduct and the deliverables we produce.
Sure. So typically, since we're dealing with administrative claims data, this data is longitudinal. So the studies that Dr. Xu and myself and Dr. Fournier as well, we typically conduct studies that are observational cohort studies. And so typically these studies, like I said, although there are various therapeutic areas, a lot of our outcomes are the same, looking at hospitalizations, readmissions, disease prevalence, and looking at emergency department visits, and looking at different risks, right? Whether it be racial and ethnic, age, sex, and chronic comorbidities, which we know play a huge deal in a lot of these outcomes that we're interested in. And typically, clients or stakeholders come to us with the research question in mind. We help them further tease out that research question, dig in the literature, help them draft manuscripts, and then get to the data. And it's a very much a collaborative back and forth process where we start with the data management, we share preliminary results, fine-tune those results along the way until we get something that is publishable. And so a lot of times we're asked predominantly to focus on peer review manuscripts, but we've also been asked to do policy briefs, and even getting into the point where we're developing interactive dashboards to make our data a little bit visually easier for anyone that's interested in perusing it. Thank you.
I know he's going to be surprised to say this. We've got one minute to go, but Dr. Fournier and I have been working on a HIPAA paper, and I only bring that up because we do our back and forth. I don't want you to think that everybody agrees at NMQF about everything that goes on here. It is a collegial relationship in which we try to get the best possible evidence, and everybody has input on it. So he and I probably, I don't know, about 6 months been working on this doggone paper, and we're probably going to try to finish it off in the next couple of months here. But that is NMQF. We are deeply committed to understanding what is happening when we look at those outcomes in marginalized populations. They are unacceptable, and the only way forward is really by good science. And so I want to thank the CCSR team and the work that they're doing both internally and externally to change the landscape and see if we can get better healthcare for everyone. So I want to thank everyone for their time, appreciate you, and again, thank you so much to the CCSR team, and I turn it back to Brandon.
Well, no, I don't have much to say besides thank you. Thanks for the team at CCSR for providing all the information and letting us know what you guys have been up to for the last couple of years. So it's really good and really thoughtful to see the growth of it. I was there in the beginning of the setup, and I got to see this organization within NMQF flourish. So that's all I have for today. I hope everyone has a good weekend, and we'll see you next week.
Thank you.
Thank you.
Thank you.